I think we're going to get it started. Welcome everyone to one of our SEM didactics on the day of our annual meeting. Really excited to be here with you all. My name is Ambrose Wong, and I'm an assistant professor of emergency medicine at Yale School of Medicine. And I'm here to host an esteemed panel of behavioral health experts and to talk about critical updates in management of agitation and workplace violence. We have no relevant industrial or pharmaceutical disclosures. And this is just a quick timeline and objectives of our session today. What we hope to do is to cover three broad topics, one related to de-escalation and potential bias within management of behavioral emergencies and agitation. We want to also touch on workplace violence and specifically healthcare workplace violence as it's related to agitation. And thirdly, but not least, is psychopharmacology and clinical management using medication sedation. And the way that we're hoping to do this is to do some case-based study discussion and then hopefully some highlights of recent literature and updates on the topic. And the six of us will do this in pairs and hoping to end each scenario with a little bit of Q&A from the audience and then ending with hoping a larger Q&A from the group. At any point, the SEM staff and some of us are monitoring the chat. So please feel free to type in questions if you have anything for us, any relevant literature or things that are happening in your own shop that you guys are doing about agitation that we'd love to hear about as well. So I have a great group here that I'm just going to ask each of them to do a quick 30-second introduction. So starting with Dr. Vrablik.
There, I'm Marie Vrablik. I'm an assistant professor of emergency medicine at the University of Washington in Seattle, and I do work in workplace violence, patient safety, and provider safety.
Thanks so much, Marie. And Dr. Im?
Hi, my name is Dana Im, and I'm an emergency physician and the director for behavioral health in our Department of Emergency Medicine. And my specialty is in quality improvement of emergency behavioral health care and also converting e-reporting time into treatment time.
Thanks, Dana. Dr. Rapolo?
Hi, I'm Dr. Lynn Rapolo. I'm one of the emergency medicine faculty at UT Southwestern, but mainly work clinically at Parkland. And I got into this because I was part of the residency leadership for about 15 years and was really tired of seeing physical assaults on our residents. And so we developed a protocol and an agitation order set and have reduced that to almost zero and recently published in JSIP Open on this with some of our presenters here if you are interested in reading that.
Thanks so much, Lynn. Dr. Martel?
Hi, my name is Mark Martel. I'm a clinician at Hennepin County Medical Center in Minneapolis, Minnesota, and a professor at the University of Minnesota. And my area of interest has been predominantly in psychopharmacology, managing undifferentiated agitation in the emergency department.
Thanks so much, Mark. And last but not least, Dr. Wilson.
Hey, my name is Mike Wilson. Like Mark, long interest in psychopharmacology. We published a few dozen articles on this. The last 3 books have been on this, including Behavioral Emergencies for Healthcare Professionals and the Diagnosis and Management of Agitation. And we're currently building a laboratory model to study this outside the ED setting for reasons that we'll talk about when we get to the end. But thanks for including me in the panel.
That's great. Thanks so much, Mike. So as you can see, we have a spectrum of expertise and clinical interest in agitation as well as research interests. So really excited to hear everyone's thoughts. And again, for the audience, if you guys at any point have any questions, update the literature, or any things that you guys are working on in your own shop that you'd like to share, we'd love to hear about that in the chat. And a quick shout out to Project Beta for people who may not be aware. This was a really great consensus effort by the American Association for Emergency Psychiatry. And some of the effort was led by members of our own team, including Dr. Wilson there. And this is really laying out some of the consensus guidelines with an interdisciplinary group of experts, including emergency physicians, psychiatrists, and allied professionals. And I really would encourage everyone to go and look at these guidelines, which is published in the Western Journal of Emergency Medicine. And we'll reference that throughout this talk as well. So we'll start with Lynn and Dana, who's going to take us off with some discussion about de-escalation and mitigation of bias when managing agitation.
Okay, next. So we'll start with the case. We have a 25-year-old female with a documented history of schizoaffective disorder with a recent inpatient admission who's coming from her group home for agitation, making threatening statements to her roommate, saying that she was going to kill her and throwing a chair across the room. The staff at the group home called the police and she arrives in the emergency department handcuffed. And the patient is screaming and saying that she's going to kill anyone who lays hands on her. And as soon as the patient is placed on the stretcher, the nurse comes to you and asks, "Doc, can you order B52? We got security at the bedside with the restraints. We're ready to go." And this is really not an uncommon situation, all while you're trying to manage a patient with crushing chest pain and also someone who's about to be started on BiPAP. So what would you do? We understand that this Zoom setting is not an ideal setting for an active discussion, but let's take a moment to picture ourselves in the emergency department and how we would respond to the situation. Next.
And I'm seeing audience members type in the chat too, so I will keep you guys updated if I hear some great thoughts and already some good discussion. Someone said, go talk to the patient. Lynn, that's right up your alley.
Definitely. Okay. So easy to go just order those drugs and to try to medicate and restrain a patient, but there are things that we need to think about beforehand because there's ramifications of sedating a patient, sometimes even too much. And most of the physical assaults take place during that containment process. So we just want to focus right now, just take a deep breath and go see the patient. So whoever said that, kudos to you. There's safety issues, so glad security got involved. And if you don't have security on board with your agitated patients, talk to your administration, because that is just a huge game changer. But the other things we need to also think about is just the patient themselves, like what's causing their agitation. So with any other patient we see in the emergency department, we need to key into those life threats, those red flags that might signal that we need to change our way of thinking and maybe do something more proactive. Maybe you need to take control earlier. Maybe it's a trauma patient that has a head bleed sort of thing. So you're all familiar with the red flags. In the next slide, thinking of what brought the patient in, their vital signs, so some in any history you can get. In the next slide. Ambrose?
Slides might not be working.
Okay, anyway, okay, well, the next slide would have talked about just like extremes of age, vital signs, history of trauma. I mean, could it be a toxic metabolic issue? Are there neurologic findings? Could this be, and maybe they had a seizure? Could it be a stroke? Is this delirium? I mean, we've heard of delirium as being, life-threatening, and definitely they don't have cognitive awareness, and somebody you definitely can't de-escalate, which we're going to talk about in a little bit. So we can go next slide to rating scales. So one of the things I want to mention is that we need to have some kind of language to risk stratify patients. And one of them is listed here, the behavioral activity rating scale, or the BAR score. And all you really need to know is just having some kind of way to stratify a patient into a severely agitated patient, somebody who's moderately agitated or mildly agitated, as that will kind of steer your approach. The severely agitated patient is the one kind of presented that was someone that's already like combative and violent sort of thing. So it doesn't matter what you have, but just think it's just, if you go into the room and you tell your nurses and the rest of your team, I have somebody who has BAR 7, everybody knows what you're talking about. It also might help you documenting medical legally. So whatever system you use, it just doesn't matter what system that is, just as long as you have one.
Next.
And regarding risk factors, we have people yelling all the time in the emergency department. And sometimes we just want to kind of ignore them and go about our way and hope they quiet down. But verbal assault, and this has been studied and well documented is a risk factor for battery or physical assault. So pay attention to those people and go see them. Maybe it's something as simple as they've just been waiting too long in the emergency department. They want a blanket, they want food, they just want attention, or maybe it might be something else. But in our shop at Parkland, we have screaming people all the time, and we assess them, and if they're really verbally assaulting us and we can't get them to come down, there's a button we push to get police, and they're there within seconds, just as backup, or in case we need to do something else, or in case the patient becomes combative, because we as physicians, as nurses, we are not trained for that. So we definitely need their support. So this is a figure that was in the paper that I had mentioned in JSIP Open that we published in just last year, and sort of a simple algorithm about how to generally approach these patients. On the left side is an arrow of increasing severity, and then the yellow boxes are descriptors of the kind of behaviors you might see, and then the middle box just explains like the level of agitation, severe, moderate, or mild. So just speaking of just the most severely agitated patient, because I think that's the one we are most concerned about, because they can become physically combative. But so they're currently violent or aggressive. They're attacking objects, such as throwing the chair or attacking people. But these patients are less likely to be able to calm down to de-escalate. And so this kind of patient, if there's no improvement with de-escalation, these patients are going to hurt themselves or other people. We need to take control, and that's where medications come in, and we'll discuss in more detail later. But they most likely may need IM injections to calm their behaviors, not to chemically restrain. Hopefully that's not a terminology that we're using anymore. But anytime you restrain somebody, you need to give medications to calm them down, because there's definitely like side effects, and things will be a lot smoother and less injuries and complications with the patient. And then because they're severely agitated and we don't know what's causing their agitation, and there's also complications, medical complications like rhabdo, acidosis, those kind of things, and they typically need some diagnostic testing and close monitoring like capnography and that kind of thing during their sedative state, and definitely close observation.
So the art of de-escalation involves recognizing and preventing potential triggers that could contribute to patients' escalating agitation. So in addition to treating the underlying psychiatric disorder with medications, we can address these 4 triggers that are easily remembered by the mnemonic TEEN, T-E-E-N. So patients perceive threat in the ED largely based on their past experiences and trauma, such as their previous interactions with the police or being physically restrained. The chaotic ED environment itself can also be a trigger to our patients, and their unmet expectations and their needs can be triggers. And these triggers then fuel emotions like fear, anger, frustration, and anxiety, leading to the patient losing self-control of their emotions and actions. Next slide. So it's really important to systematically assess and implement interventions to address these triggers to help patients find their own internal locus of control. And in the case earlier, our patient had a past trauma of being assaulted by a male partner, which left her feel unstable and very vulnerable around male healthcare providers. So we provided trauma-informed care by replacing male staff with female staff to de-escalate our patient. We also try to improve the treatment environment by removing unnecessary bystanders. And we try to set expectations early regarding the delay in psychiatric evaluation to avoid any disappointment. And we acknowledge her anxiety and offered her medications. And in this case, oral or IM medications are offered. And she actually elected to take IM droperidol because that worked better for her the last time she was in the ED. So really allowing the patient to control the situation went a long way. Next.
So I just want to briefly just go over de-escalation, which is a powerful tool and as a game changer if you don't already know this. And many of you already do, but just wanted to just briefly go over it. There's many approaches. Project Beta has a nice paper just dedicated to de-escalation alone. But here's just a simple acronym that if you are an acronym person that you could remember, just being just empathetic, to listen to the patient, to agree with, even though they're not saying something that you completely agree with, but just kind of acting like you agree with them and partnering with them. And then just in the next slide, there's some phrases that you can use. And all of us can do this. And it's at Parkland, the nurses call me the ghost whisperer for agitated patients. And I'm not sure why they say that, because I'm not doing anything anybody else isn't capable of doing. But these are the phrases that I use and that will help you de-escalate somebody, and just some keywords such as I am here to help, introduce you or them yourself to them, kicking people out of the room. If you could imagine, if you're a paranoid schizophrenic and you're having these delusions and you think people are going to hurt you, if you have a lot of people in the room that are trying to approach you and somebody has a needle to give you some medication, I mean, just can imagine where they're coming from. So if you can get them to look at you and just listen to you and just engage them for a few seconds, most likely you can de-escalate this person. So just emphasizing you're there to help, that you're on the same team, that you want the same things. And most importantly, let them know over and over again, sometimes you have to say this, that they are safe, and no one is going to hurt you. And just the nonverbal communication is just as important as what comes out of your mouth. So coming down to their level, just being safe, staying at a safe distance so they can't spit at you, they can't hurt you, having your back toward the open door sort of thing. And I usually keep at least one police officer in the room, but I do kick everybody else out because that's just scary to have all those other people in the room.
So I want to take a moment to acknowledge the role of implicit bias in managing agitated patients in the ED. So recent studies by Dr. Wong on this panel and another group in Boston have shown that there are significant associations between restraint use with male sex, Black race, and other socioeconomic factors, including homelessness and insurance status. Even arriving to the emergency department at night can put you at a higher risk of being physically restrained. And these studies make us wonder, how do these factors actually influence our perception of threat when working with disruptive or agitated patients, and how our decision to restrain patients is made in our clinical setting? Next. So one way to really mediate this, and this is something that that our group at Brigham and Women's Hospital developed, is to build an agitation management workflow or a protocol, and train ED staff when possible to pause and reflect on why the patient is being perceived agitated or violent. And is it because the way they're dressed? Is it the skin of their color? Or is it because they're 6 feet tall? And really deliberately taking a therapeutic approach to managing our patient rather than a punitive approach. Next slide. And this is another nice algorithm created by a group of EM residents in Boston to remind our ED staff to systematically perform bias check when it's possible and when there's not an immediate threat to physical safety of the patient and staff. Next. I think we can take questions.
Have any questions they'd like to raise about?
I'll ask a question if nobody else has one, if that's okay. And it's really about training de-escalation. I know that you have listed some great references for what are possible, best practices for de-escalation. Unlike nursing and security, physicians in general don't have any formal training on de-escalation. I don't. I went to our psychiatry folks. I said, what was your training on de-escalation? They said, we don't have any training on de-escalation. Are there training options, or is there sort of best practices in how to train your staff for de-escalation?
I don't know if there's best practices, but at Parkland, they put our nurses, and we actually started putting all of our residents through this called SAMA, S-A-M-A, and I apologize I can't tell you what the acronym means, but it's not just de-escalation, but it's also self-defense training that they get. The nurses go through a whole day. We put our residents through like an hour, but then we do some simulation And it's a discussion we have at conference. I don't know if anybody else has any comments on that.
Yeah, so what we're learning right now at our shop is that a lot of these de-escalation training programs are very law enforcement heavy, and not a lot of trauma-informed care techniques are actually incorporated. We're currently working on actually making a homegrown one just for emergency medicine providers. And, a lot of these programs are actually not ED based. So just taking that opportunity to think of ways to incorporate cases and also techniques that are specific to ED environment would be key.
And you know what, Dana, I would sort of be remiss if I didn't kind of follow up with that and say that the Gaines citation that I put in the chat is a systematic review from AHRQ and showed that verbal de-escalation works well, although there was insufficient evidence in their review to recommend a type. We're kind of fans of Janet Richmond's paper, which was a directed for the ED. And to answer Casey's question, does contain some best practices. It boils down to those 10 things that Ambrose put in the chat.
Yeah, it's a great question. You see, there is no standardized training that's evidence-based in de-escalation, unfortunately. A lot of institutions and hospitals purchase proprietary products that I'm sure you guys might be familiar with, including CPI or MOAB. It runs a gambit. I saw a list once from a behavioral health expert, and there's 30 products. None developed well for the emergency department. One thing that Dana and I have been working on is creating simulation scenarios and tabletop exercises to practice some of those de-escalation techniques tailored for us in emergency care. But yeah, it's a really good question. And then I just wanted to, before we move on, quickly point out, I think Marie made a good point. Dana, I think the yes and no on the top part here may have been flipped.
Yes.
Just that if there is immediate threat, we would move to the right and apply appropriate restraint. But if there is no threat, then go to bias check. Sorry,
yes,
just wanted to clarify.
That would be true.
She did that on purpose to make sure you're paying attention.
There you go.
Thank you, everyone.
Great,
so we're going to hand it over to Dr. Vrablick, who's going to take over to talk a little bit about ramifications about healthcare workplace violence and some of the work that we've done to try to look at how we can prevent that from happening. Marie?
Thank you, Ambrose. And also, just before I get going for the SAM staff, I'm noticing that people were asking about collating our resources. Would it be possible for the SAM staff to capture the chat? Is that something we can do?
Absolutely.
Oh, great. Okay. Thank you so much. Okay. Well, let's jump into case number 2. So this patient, JP, presented in a slightly different version in real life to myself in May 2020. And I'm certain that many on this meeting may have experienced a similar case in the past summer or further back in their careers. But this patient was an agitated patient who was brought in by EMS. He was also in the custody of police. He was a 20-something-year-old male. He had been in an altercation and appeared to have an abrasion above his right eyebrow. He had been involved in a protest that had ended with some breaking of windows. He was subsequently arrested. When he arrived to the stretcher, he was screaming, threatening the staff, attempting to move him to the bed. He ended up having physical restraints applied. He was spitting at our nurses. He was using racial epithets. And this was certainly a highly charged scene. And I hope people are recalling some of their own emotions when maybe they were involved in similar cases. One of our bedside nurses was crying. During the restraint process, unfortunately, the nurse was kicked in the stomach. She left the care area, and then the charge nurse approached and said, you know, this nurse would like to press charges. And she told the officers at the bedside and also told the physician, myself, that the nurse would be checking in. What would you all do next? And as Dana mentioned, you know, we don't feel free to jump in the chat and say what you do next. I think we all know what we would do next. We would do what we all are trained to do, which is take care of our now 2 patients, JP and the RN checking in. But I want you to think about what you would do tomorrow and next week and next month, and what will you do to approach this situation that has happened and probably will happen again at some point in your career. And with that, let's move into some more detailed concepts. First, I want to touch on what I experienced and my nurse experienced, which is really this concept of a patient care paradox. Increasingly, we're seeing media coverage of violence against healthcare workers that happens in their place of work. And so this concept is in our minds as physicians and providers. Also, we are thinking, I'm sure, of our patients whom we're trying to provide care for. But we're also faced with this paradox of, we want to care for this young man, JP, but we also recognize that this is a terribly traumatic time for him. We're trying to help him, and he is being restrained to a bed, and he certainly may end up with arms that look like this picture on the right. And this is a real source, I think, of moral injury for us as care providers. And this term, patient care paradox, was coined by one of my panelists and collaborators, Dr. Wong. And on the next slide, we'll see the title of his paper. He and his research group looked more deeply into this phenomenon through a qualitative study of agitated patient care in the ED. And they met with different care providers, nurses, attendings, and residents, and really looked at how did this feel and what was weighing on these people as they provided care to these patients, and how did they reconcile and cope with this care paradox. And then, that sort of begs the question of, what about the other half of that behavioral emergency or ED encounter that ends in violence? What about the staff who experience violence as a result of their care in the ED? And that's an area that I have done some work in, Ambrose and I have published in, and I want to talk a little bit about, we've talked about behavioral emergencies, and now let's talk about workplace violence as a result of those emergencies. We know that workplace violence happens frequently. We know that, based on the literature, that nurses are most at risk for reporting physical and verbal assault while at work in healthcare. We also know that a large portion of non-nurse and physicians are assaulted at work. Medical assistants, even environmental services. 40% of these healthcare workers report assault. And then a really startling statistic, one paper reports that healthcare workers are actually experiencing workplace violence at higher rates than law enforcement. And I think that's really a staggering thing to think about. So we know that this is happening, and we've known this for some time, this phenomenon of workplace violence in the ED. And next slide. So with this in mind, and really thinking about, we've already answered the question, is this happening, and how much does this happen? My research team and Dr. Wong embarked on this multi-site study looking to understand how are our workers impacted by these experiences of violence. And then we really looked to develop a systems-based framework to approach coping with these episodes, from a systems base, from a healthcare and hospital administration base, and really a departmental based approach to mitigating the experience of workplace violence for our healthcare workers, for our team. Next slide. And this is a graphic that we put together based on our work with interviews with workers who'd been assaulted at work. And we involved a systems engineer in our study, and we looked to sort of make the phenomenon of a violent event more digestible and break it into parts, so we could design tools or interventions geared at each of these parts of what happens before an assault, what happens after, and what happens as an institution down the road. And we broke our framework into 3 levels: micro, meso, and macro. And micro is really what's happening on an individual level with this event, what's happening to the individuals involved. The meso level is really sort of departmental or hospital administration, what's happening on that level. And then our macro level is really more of a worldview or societal level, what's happening out there in the great ether, and what's our conceptual approach to this workplace violence as it unfolds. We also recognize that workplace violence has a temporal component, meaning there's the before phase, there's the immediate aftermath phase, and then there is the subacute or recovery phase. And you'll see we have prevention, response, and recovery to a workplace violence event. Next slide. So just with that really big overview and sort of introduction to some of these concepts, I want to suggest that maybe things like this may play into your care for this patient or for the next patient you see like JP. And I would suggest perhaps acknowledging both internally and to your team this care paradox that's certainly happening for all of you. This is a tense situation we're all struggling with. We want to help this patient. He's in distress. He's scared. There's potential for him to get hurt, us to get hurt. I recognize that this is a challenging time and we're going to move forward as a team. And if you want to try to involve the patient in that discussion. Sometimes it's really challenging because of their agitated state of mind. I feel obligated just to touch on bullet point number 2 that we won't cover today, but I think, does play into this case in particular, and really these big picture questions, the interplay between the justice system and healthcare. And that's something important to consider, and certainly an area ripe for more discussion and research in the future, and did play into my encounter. And then finally, and we'll share this citation, but I would recommend being familiar with this micro, meso, macro approach, and then thinking of your workplace violence event in temporal phases. And so in specific, this case, it's our event has happened, the violence has happened, the assaults happened, and so we are immediately in the response phase. When you're in the response phase, if you can, think about your 3 levels, you're immediately, of course, going to deal with team dynamics, interactions with your staff, principles and biases covered previously around restraints. You should be familiar with your hospital policies. And then, of course, you're going to be thinking about cultural and medical legal conceptions around workplace violence and its aftermath. Moving forward, as a physician and a provider in the ED, you have the opportunity, I think, to really positively impact your staff and hopefully your administration and how these types of events are coped with. So you should consider being familiar with your own coping style, your staff's coping style, debriefing protocols that are in place or perhaps needed at your institution. Other institutional support resources, for instance, the University of Washington has a peer support network, and I would recommend understanding if your institution has that resource for staff members. And then finally, thinking about the global issues of legal recourse and the ethical dilemmas that will come out of cases like this, and preparing your staff similarly. And I think that is the end of my session, and I'm happy to take any specific questions. I saw a lot of chat alerts, but I didn't open them. So Ambrose, if there's anything you think we should cover, please jump in.
Yeah, just a quick highlight. There's been a really good discussion in the chat. One thing that Dina mentioned that was really great was sort of naming the actual paradox and the moral injury that you mentioned, which is really great. Appreciate Dina for the shout out. And then just wanted to highlight that our moderator, Casey, published an article that I didn't realize was his. I put the link in there and he's like, that's my article. So that was really exciting. in the Western Journal of Emergency Medicine that was talking about what you mentioned, Marie, that it's not just the MDs and the nurses, although obviously the nurses, especially the ones that are at the forefront of workplace violence, but they surveyed other allied health professionals with their workplace violence in their ED and noticed some high rates with them as well. I don't know, Casey, if you want to spend just a minute or two talking about what you guys found.
No, there's just nobody that is not at risk for that. I think that we should open it up to questions for those who are interested. Is there any questions for the team? And maybe while you either put it in the chat or raise your hand, I'm interested, Marie, what was the police's response when the nurse said that they wanted to press charges?
To be honest, Casey, I may have introduced that as part of my case, but I can think of other times where that has happened, and I would say the responses varied. Some officers say, you know, you can't, and some officers say, yeah, I'll call someone down and they will be here to take your statement, or the nurses provided a card. And sometimes, and most frequently for me, it doesn't happen really in that time capsule that was my artificial creation, but rather it happens later.
There's a question from Dina that says that she'd love to hear how the staff and patients have responded to the overt naming of the care paradox, as you state. And what words did you use? Did you do this in a huddle outside of the room or right in the room with the patient there?
I did not. Thank you, Dina. That's a great question. I did not use the term care paradox for a lot of reasons, probably most because I didn't, review Ambrose's paper right before my shift, not knowing that this was going to happen, but also probably because I didn't think that term would be easy to understand. I think really what I did was I knelt at the bedside to try and make the patient feel safer. And I said, I know you're scared. I know you're upset. I am too. We all are. And I tried to be really open with him and calm. And I tried to stay there with him. And I will say, also, this is just so you know, a very, charged topic for me because it did happen. So I apologize if I seem, a little shaken, but the young man was Black and our security officer was Black also. And that really was a helpful thing in this highly racially charged time for this man and our country and our local area. And he just used words like, I am here with you. I want to help you. This doctor wants to help you. And we tried to invoke what Lynn mentioned, which is we're on your team. And I think it was hard and it could have gone better. And I really appreciated that team approach. And I can't echo enough Lynn's statement that it's really important to involve your security team with you, because this really should be about a shared de-escalation, which is what my case was, not about punitive or, in any way making the patient feel that he made a mistake or did something bad. We really wanted him to know that we recognized, at least tried to empathize with what he was experiencing, and we weren't mad at him. And it was hard. And I think only by playing these scenarios out, tabletop, like Ambrose says, or in a sim situation, can you at least in part take away the emotional weight of this? It's very hard in reality. I hope that sort of answered the question.
I think that's a great answer. And go ahead, Ambrose.
Oh, sorry about that. I was just saying that was great, Marie. And I was going to reference back to what Dana said too about trauma-informed care, and how that helps both your assessment and interaction with the patient, but also recognizing the trauma that you might have experienced yourself as a healthcare worker during these episodes. I recognize that we're short on time. I'm going to move on to Mark and Mike, last but not least, to hopefully touch on some psychopharmacology and some clinical management of agitation. So I started out with just pointing out Mike's contribution within Project Beta related to psychopharmacology and some of the best practices that they mentioned there. And then I can also move on to Mark's slide, which highlights some of the recent studies. So I'll hand it away, Mark and Mike.
Thanks, Ambrose. I wanted to use this time a little bit just to kind of highlight some of the work that we've done at Hennepin over the last year or two, really addressing kind of psychopharmacology and some of the issues that we face practicing in the ED. And then hopefully Mike and I can have a chance to kind of talk a little bit together. There's been a couple of exception from informed consent studies that we've done. Just a reminder, in 2005, we published some work looking specifically at droperidol, ziprasidone, and midazolam for patients who presented agitated. And something just real quick to kind of step back about Hennepin, we do have a special area where we care for predominantly intoxicated, agitated, and patients with mental health or behavioral concerns. We recognize this is unique and not everybody has the luxury of this kind of separate care area that's staffed just like every other area in the emergency department. One thing about our research that we probably need to mention is that a lot of our agitated patients are ethanol intoxicated. Not exclusively, but somewhere, in the neighborhood of 80% of the patients that we're talking about when we're looking at all of these studies. So back in 2005, we looked at droperidol, ziprasidone, and midazolam, and saw that droperidol was extremely effective at 15 minutes in managing agitated patients, more so than ziprasidone. Pretty similar to midazolam. The one thing about midazolam we found in that study was that folks often required additional rescue sedation. Kind of coming up to recent publications in 2020, we had a follow-up study that was done in line with that EFIG that we just talked about. And this was looking at droperidol, 2 doses of ziprasidone. In the previous study, we used 20 milligrams. In this study, we looked at 10, 20, and then used lorazepam for sedation. And essentially, droperidol was more effective than any of the 3 drugs at 15 minutes and had fewer episodes of respiratory depression. There really was no difference in rescue sedation between the 4 drugs. So again, now we found a group of medications that were reasonably effective. Droperidol was faster, but then again, no rescue sedation was needed looking at the different benzodiazepine in this study. Perhaps, I know droperidol is very near and dear to my heart, something that we've been studying for a long time. But in 2001, there was the black box warning that came out. Well, we wanted to publish some data that we had about QT prolongation with droperidol. And in WestGem in 2020, we published a paper looking at more than 16,000 patients who received 18,000 doses of droperidol. And we saw that we had about 2,800, so just under 3,000 patients had EKGs performed. And we saw only 1 episode of torsades in this entire group of 18,000 doses, meaning the incidence was 0.006%. We politely stated that we felt that the black box warning might be overstated by the FDA. So just a little background. Well, and I think that's important because droperidol is a whole lot more available now. Obviously, it was not being produced. There were a lot of shortages for about a decade. We did a lot of studies looking at olanzapine during that time. And now that droperidol was back, we kind of wanted to compare these 2 drugs head to head. We actually did an observational, thanks Marie, asking how the FDA took that. I don't know. We have kind of a working relationship with the FDA. We haven't heard a response, so I'll hold tight waiting for the letter. But getting back to droperidol and olanzapine, now that we have these drugs available to us for the severely agitated patients. And I think that each of the cases that were just presented were really fascinating and very well handled. But again, there are cases where folks need some intramuscular sedation for their safety and for the healthcare workers. Looking at these 2 drugs in an observational trial, it was interesting. There were kind of natural shortages that allowed us to independently look at droperidol's use and then olanzapine's use. And we were able to look at about 1,300 patients. There were about 500 patients in the droperidol group and about 700 in the olanzapine group. And again, admittedly, most of these were intoxicated with alcohol, but we had a good chunk of patients with illicit substances and psychiatric causes, and they were included in this. We found no difference in the time to adequate sedation. We saw that droperidol required less rescue sedation. About a quarter of the olanzapine patients needed rescue sedation. We did see that extrapyramidal effects were a little bit more frequent with droperidol. That's obvious. So olanzapine has that benefit. It was 1% of droperidol patients had extrapyramidal effects versus 0.1% in the olanzapine group. With this data, though, because of our predominant alcohol intoxication, we really tried to do a subgroup analysis, because the biggest criticism is how do these drugs perform with, bath salts or the other kind of novel drugs that are coming out there. And we found that there was no difference in time to adequate sedation for these severely agitated patients with either psychiatric causes or meth. Well, speaking at time to sedation, we are also very concerned about how long folks are in the emergency department or sedated before they can receive mental health care or have that psychiatric consult. And we can't really answer this question perfectly, but I can say that with our predominantly intoxicated group, we looked at more than 40,000 intoxicated patient visits, where they received almost 12,000 doses independently of an antipsychotic agent. The majority of these received olanzapine, about 6,500, and almost 4,000 patients received droperidol. Now, we can't forget haloperidol, because it's still out there and used. I have to admit, I'm not totally sure why. And there were about 1,500 patients received haloperidol. The median length of stay in the ED was shorter with droperidol by about a half hour compared to either haloperidol or olanzapine. And that pretty much remained true whether or not there was Benadryl added. The last thing I wanted to point out is that there are cases where we're dealing with pediatric patients who are in this situation, who are agitated. Really difficult question to answer, but we looked back at our pediatric patient population who received olanzapine, and we found almost 300 kids who needed medications. Now, 166 of them received the drugs for agitation specifically. The median age was about 16 years old, but we had a range of 9 to 18. We found that it was very safe for not just agitated patients. We saw a small incidence of hypoxia, about 2.4%, but less than 1% needed any oxygen. Overall, I think what was really important here is that you can feel confident, at least based on this data, using olanzapine in agitated children. Just kind of a quick overview of what we've done, hopefully answering some of the questions or giving you some guidance. And again, remember, these are severely agitated patients.
Thank you, Mark. That was great. There was just one question from the chat about ketamine versus droperidol. We were wondering if we should bring up ketamine or not, but it was this discussion.
So ketamine versus droperidol. Nothing head-to-head comparing these agents from our group. We tend to use droperidol predominantly in the ED. Ketamine is used for severely agitated patients, frequently then to kind of manage the situation immediately for patient safety, and then transitioning to something longer acting. I think the biggest thing that we've seen in using ketamine alone, it's similar to midazolam in that it controls the situation very quickly, but then needs additional sedation. Is our psych department on board with droperidol use? Absolutely, absolutely. Very supportive. I think it's very different.
And Marie, to answer that too, our department has wholeheartedly adopted droperidol, which I was very pleasantly surprised to find. Fortunately, pharmacy was one of the champions to really sort of change the mind of our psychiatry colleagues and some of the regulatory colleagues in our hospitals. So, and then we actually went into a parenteral haldol shortage for about 3 months. And so that really rapidly pushed us towards droperidol because they recommended basically Thorazine or Zyprexa. And we said, no. So
And,
now we have started using droperidol quite a bit in our department.
and Ambrose, if you don't mind, I'd love to follow up Dr. Martel's excellent words with a couple of thoughts to kind of close out the psychopharm section, if that's okay. I know we're a little short on time, so I'll make this really, really quick. And the first thing I need to say, or I think needs to be said, is we should really offer some huge kudos to Dr. Martel, Drs. Vrablick and Wong, Dr. Im, Dr. Ropolo for all of their valuable work in this area. These really are the agitation scientists in the country, the folks that you're talking to right now that are doing the most innovative prospective research. All right, now for some controversial statements so we can really get the chat jumping here. You know, we have spent so much time asking if we should use a particular drug like droperidol. We've not stopped to ask which patients is this good for. The field has been dedicated to showing that it's good for everybody. It's great for hair loss, weight loss, whatever. But we're not really asking which patients is this good for, which one should this be given to? This really goes along the lines of what I call the one drug to rule them all argument. And if you are hoping to come away from this session with one drug to remember, this is probably not the session for you. I'm going to try and convince you that we should be treating based on the causes of the agitation, not just the drug name. Let me just say another little controversial thing. We started off in our first scenario about with the scenario about asking for B52. I'll just point out that the evidence for B52 is far greater on Facebook than it is in the actual scientific literature. It's never been studied prospectively in the ED. If you are using it, you are practicing medicine by social media. One more controversial statement, or this is actually probably not too controversial. In our recent systematic review, which I put a link in the chat here, we found only moderate evidence, even with all of the great work of the folks on this panel, we found only moderate evidence in the ED for any particular drug combo. And when you read these Cochrane reviews, they are taking from settings outside the ED. And as Ambrose has shown us, that's probably doesn't generalize well. I don't care what the FDA says. We will not make progress in this area until the FDA changes the EFIC regulations. We simply can't study the way we would like to here in the emergency department. So if any of you have contacts at the FDA, please talk to them. All right, now one last controversial statement. I'm going to give you a summary of the amazing evidence that Dr. Martel just gave you and put a slightly different spin on it. So I think what you heard from Dr. Martel is an argument to use droperidol in substance use disorder patients. In the studies that he cited to you, the substance disordered patients range from about 86% up to about 93%, depending on the study he was talking about. I think he makes compelling argument actually to use droperidol in those folks. However, if you dive deep into the tables in some of those studies, you'll find that droperidol actually does worse for patients who are there for psychiatric causes. I'm going to argue again that we should be treating our patients in the ED based on the likely cause of their agitation, not on the particular drug name. And that's the first thing we should think of so that we don't end up giving antipsychotics inadvertently to folks who are really there for medical causes. So again, kudos to my fellow panelists. Thanks for all the amazing work you guys are doing. And Ambrose, I'll turn it back over to you.
Thank you so much, Mike. I noticed we're actually over time, so I'm going to just formally end the session there. But if I think a couple of us are willing to and able to stay around for any questions. And Mark, I think you wanted to make a closing statement. Is that correct?
Yeah, I just wanted to say that Dr. Wilson's point is very important. Sometimes we're unable to tell this right away, what the etiology of agitation is, but treating the cause is the most important thing. And then I'd also put in a plug that exception from informed consent research is critical in this area. The FDA has really blocked that, and I would be happy to talk for a long time about this offline.
Thanks, everyone. And I think we'll call it at that for those who want to take off. I'm going to stick around for just a second because I have a question for the panel.
Also, the panel could keep going, I'm sure.
Yeah.
We love talking about this stuff.
Yeah, I guess my question.
Go to phone.
So my question is you have, this has been just the best hour. And I know that you all seem to have worked together on a lot of this stuff. And for those of us who are working in the workplace violence / agitation workplace, is there an opportunity to collaborate across sites with your folks? Do we create a network to actually do this? I actually run what we call complex behavior, which is workplace violence for the Mayo Clinic enterprise. I'm the staff safety officer for 63,000 employees across our enterprise. And so I would love to collaborate with you all on being able to study this and do this. The paper that Ambrose linked, there is a follow-up study to that we've done across all the EDs in the Midwest. So we have a lot of interesting data, and is there an opportunity to work together or have a network on this?
Let's do it.
Yes, let's do it. I wanted to mention, doesn't SAM have a new behavioral emergencies interest group? Because I was on the call and it didn't seem like there was a lot of people there. So it just might be like a forum that would love to collaborate. This is an awesome group. I've loved the discussion, and I just feel so happy and honored to be here with y'all.
Well,
oh my God,
you
can see that in the car.
You lost your background.
Casey, to answer your point, yes, there and Lynn, there is a behavioral emergency or behavioral interest group. I've been on that for about 2 years, and Bernard Chang is leading that. Amazing
That's
guy.
Right.
It's interesting because the folks that have come into that group are both folks who are interested specifically in the field of behavioral health, and also folks who are in other areas of research but looking at behavioral outcomes related to health, like cardiovascular research but looking at behavioral outcomes related to it. So there's been sort of a continuing discussion about the identity of that interest group. But Casey, please feel free to join our Rat Pack here. It's sort of been an informal group of us working over the last couple of years to build different areas of research. And so Marian and I have worked together, Lynn and I have worked together, Dana and we've all sort of worked in different ways, but haven't formally created a coalition, so to speak.
I wonder if there's a benefit to that, though.
Absolutely.
I don't think it has to be big and formal, but I think that, I worked on sepsis for many years, and there's a group of people who work in sepsis, right? And we all talk to each other. And I don't know that apparently that does exist for agitation and workplace violence research, but I didn't know that you all existed in that way. I knew Mark's work because he's up the road and we used all of his data to keep Preparedall here. But I would love to work with you all. I have actually a senior resident who's soon to be a fellow who is intending to make this a career direction for her as well. I was texting her while you were talking. And so I think that it would be great to do that. And I won't take any more of your time, but I'll try to reach out by email.
Stacey, feel free to reach out as well. Just sort of scanning through Google Scholar, you've been a lot more active in this than I realized. We would love to hear about your contributions as well. So thank you.
Sure, happy to. Thanks a lot.
We need to be a force to make change so that patients hitting ED staff is a thing of the past. So I'm
Yeah.
not going to stop being part of this until we're talking about, remember when the patients used to hit us, those kind of things. And so there's a lot of us, if you have any ideas of how we can brainstorm to be more of a force to reach out to more people, because we know there's so many coexisting interests and that kind of thing. We'd love to be part of it.
One of the things that we've done that I think has been really helpful and is the start for changing the culture is build a community collaborative. So I asked you the question about how the police responded. We realized 4 years ago that we had a terrible relationship with public officials, right? So we now meet quarterly with everybody at one table. So there's the county attorney, the city attorney, the chief of police, the sheriff, the legal department from my hospital. It's about 45 different people, and we've done 50 rapid cycle projects to improve about how we communicate, what are appeals process, how do we get help when we need help, how do we convince the beat cop that the person who got hit was hit by somebody who was lucid when they did it. And it's been really effective. So I have in my cell phone the county attorney's number, the chief of police's number, and they want to be called 24/7 if anything is going on. And so that sort of community collaboration is good. I haven't figured out a way to be able to publish that because it's not really outcomes. It's more of a conceptual framework. But I'd be interested in all of you guys' opinion on it. But again, it's past your hour and I don't want to keep you. I want to be respectful of your time. I will likely be reaching out to you all by email. So thank you very much.
We would love that. Thank you.
Yeah, thank you, everyone.
Thank you.
Thank you.
Thank you.
Thank you,
Take
Ambrose,
care,
for
guys.
coordinating.
Yeah, yet again.
Great job. Thanks, Ambrose.